Okay, so do we have any questions for our wonderful speakers?
So I'm a mere junior doctor, so I don't know quite how all these contracts work with NHS. But if these companies are not meeting the standards and are not working towards net zero, is there the competition that you can stop using them for their product or service? Is there the competition and the other services to step into that place?
Hi, I'm Paul. I work for NHS England. I work mainly in travel and transport, but I have worked across some of the net zero teams as well. I guess the answer is it depends what you're buying and what the alternatives are. For example, we've thought really carefully in the pharmaceutical industry about generics. They're generally manufactured out in South Asia. Are we genuinely going to say if you don't cut your carbon footprints in line with maybe some of your European competitors, we won't buy from you again? Maybe not. There'll be materials that are patented or just for other reasons essential. So it's not a case right now of saying if you don't tackle your carbon footprint right now, we're just going to stop doing business with you. It's not as clean cut as that. But what we've made a really world leading commitment is to say, like, you've got a few years to do this, and we will be making contingency plans in the meantime. And if you continue not, and we've set out a really clear pathway. You can find it on the Greener NHS's website about what we expect all suppliers to do by when. So not a case of just turning the taps off now, but really clear pathway which everyone's expected to do. And increasingly, some of the things that we're asking people to do will make good business sense for them as private entities as well, moving to less packaging, moving to renewable sources of energy, moving to cleaner transport. We'll all have a long-term intrinsic business benefit, but the NHS are backing that up with saying that, you know, by 2030, 2032, if we don't see enough benefit, we are prepared to walk away from you as companies and spend our money elsewhere. So it'll be different for different suppliers, but yeah, we are serious about that.
Yeah, and I think just to echo that, so I do some work with the ABHI as well on their sustainability group. So that's the Association of British Healthcare Industry, for those that don't know. Again, as Paul alluded to, there's a procurement notice. So at a certain point, I think it's about 2 to 3 years' time, you will have to comply with this notice. Otherwise, you just will not be awarded new business in the NHS. So the existing contracts will take a bit longer probably to sort of to turn over, but particularly for new, I think most suppliers now are looking at that very aggressively. Obviously, the bigger corporates, it's taking longer because they've got much more machinery, but a lot of the SMEs are aggressively tackling net zero. And again, there's a lot of different mechanisms. So part of that is, yes, no, binary, you can participate. Others are scoring systems, so social value, environmental value. A lot of those are increasingly becoming more important as part of procurement exercises. So I think what we'll see is a gradual transition over time as some of those things embed.
Fantastic. Any other questions?
Hi, thanks for the presentations. I only saw the last bit, but it's very interesting, thank you. I'm an orthopaedic surgeon and also business development director at Encode Health, and we're quite interested at looking at streamlining surgical inventory to clinical needs. And my question really around net zero is what's being done to address supply chain inefficiencies and stock holdings and equipment coming in and out of hospitals on a regular basis. Is there any sort of plan for that?
I guess I'll start on that and then I'll hand over. So yeah, nice to meet you. I'm Piyush. I'm also an orthopaedic surgeon, but I think from the background, I'm not aware of anything at local levels that looking at stock management. There's so Prof. Mahmood Bhutta did some fantastic work. He published a paper on, in terms of your set. So can you start removing equipment from certain sets because you use them once every 10 cases, having those separately packed? So that's a very sort of low level individual case base. What I don't know is then how does an organisation go to manage their entire inventory, including things like loan sets and loan kits? My feeling is that's probably very varied. I suspect there's probably good pockets of people doing it very well, but I'm not aware of a coordinated approach unless Paul or someone else.
Not nationally, but I have worked in hospitals and managed orthopedic units before, where we have completely streamlined the numbers of implants, for example, that are available, and really tighten up the loan kit arrangements so that you have to demonstrate a need, you have to plan in advance. We were seeing a huge variety of implants going on, and some of them weirdly expire, and then you have to you waste that money and don't know what happens to them. I doubt they get chucked in the bin, but that's all waste. And as one of the previous speakers says, if it's a waste, it's got a avoidable carbon footprint attached to it. So there's some really good examples of London hospitals out there. King's was the hospital that I'd worked at. I've done similar work with St George's. There's a lot of work out there about how you just streamline your stock management, your stock holding, the range of different items that you have, and make sure you have a first in, first out stock control mandate. There's nothing national, but there is really good pockets of good practice elsewhere.
Yeah, I think there's going to be some really good solutions out there that's going to help. I know it sounds like you've got one yourself. So yeah, we'd look forward to hearing more about that at some point. And I'm currently working with the Florence Nightingale Foundation on their Greener Leadership Programme. This is a programme that gets nurses to be leaders within sustainable healthcare. And we've had quite a few of them over the last few years that have been working with supply chain, especially in this areas of single-use packs, where you have sort of big procedural packs, where they've been working closely with clinicians and then going back to their supplier and saying, well, those 3 sponges and that kidney dish, we don't use it. Why are we putting it in every single supply? And then that's starting to spread nationally now. And so these little swap outs are going to be really, really impactful. Any more questions?
Thanks a lot. So, Piyush in particular, in your presentation, you touched on the leveraging of digital solutions, this kind of systematic approach to delivering healthcare, and the knock-on effects from a net zero, a carbon impact are pretty intuitive. But whilst it's easy to see the benefits, there can be quite a lot of complexity involved with the people involved, the change management aspect. So, have you got any golden tips and advice on how to manage that side of things in order to realise the gains?
Yeah, absolutely. I think you're dead right. So the change management is definitely the most difficult for any of the scenarios. I would ensure you've got appropriate internal resources. So don't just say, oh, this is a supplier's problem, or we bought X, it needs to happen. So again, my trust, we've now set up digital teams, so we have not just the CCIO in post, but actually divisional leadership, and then that cascades down. And again, if you can resource that and create proper infrastructure, that will then serve you well, because then you can bring in more and more solutions. So I think having resources and funding that are actually earmarked and ring-fenced to achieve that is probably the best way. Whereas if you're trying to ad hoc it and you don't have a process, or you're relying on your suppliers, then you often become unstuck, because this is complex change. So it's about, can you create that this is going to be the next 30, 40 years of the organisation, and get the exec to buy into that, because ultimately that's the way it's going to be solved. And not, different trusts are different, so it can be quite tricky.
Thanks.
I can just add to that a little bit. I think, like I alluded to it in my talk about the shared values thing. I think obviously identifying where in like a corporate or a local national strategy the change fits in, and then going for like a bottom-up approach, which is like your staff networks showing that they want that, and then a top-down approach as well, can really be very powerful. And a lot of the staff will volunteer and do a lot of that stuff for free, actually. Like in the Green at Barts, obviously it was just additional things, but because they care about it and they want it to happen, they will put in that time, and then that really helps the leadership to then bring the resource and kind of prioritize it, and it will push them to be more ambitious as well. So I think really using the people that you've got, like kind of optimally, not just thinking that's going to be a senior-led decision and go down, is really powerful.
So, Nadia, while you've got the mic, I'm really interested to know how you've engaged patients throughout this process. I think it's something that we often negate in all of this. I certainly do, and you can tell most of my work is back of house now and sort of in the plant room. But please, it'd be great to hear what your sort of experience with that.
Yeah, it's ongoing, isn't it? I mean, I think as a paediatrician, we try really hard to have the the voice of the child very prominent. And I think the Royal College of Paediatrics has done quite a lot of nice work that working with kind of a focus group of RCPCH and us, who are like a group of young people who help kind of do focus groups and kind of working around like what they think the priorities are, what they want pediatricians to focus on, and how they want us to kind of be trained in the future and things like that. And I think that's obviously really useful. So that kind of patient and public involvement kind of approach, as in a kind of research context where you say, what do you want us to do? What do you think? How should we serve you? Which is, obviously the whole point of us is to be serving, our patient group or the public. That's why we're here. So I think just that kind of engagement work. I think otherwise it's quite difficult, and it can be a bit amorphous. Like, well, how do we fit together? And should we be but I think for pediatrics, it's a little bit, it's clear. And I suppose the thing is, if the public at large are saying that we want the government to prioritise these things, we want clean air, we want clean water, we want green spaces, then as people in healthcare, like, we should be listening to that and kind of responding to it. But that's a bit macro. So I think, with regard to the patient in front of you, I think offering like the stuff, like feeling that it's within our remit to offer advice about air pollution and things like that, rather than kind of thinking that's something political or something controversial. I think sort of keeping an eye on the health benefits and the health approach to good health.
Fantastic. And Piyush and Paul, how about yourselves with patient engagement in your projects and work?
Yeah, we have a PPIE committee that we actually asked, and there's some fascinating work that's come out of that. One of the particulars around sort of shared decision making, so surgery or anaesthesia being one of them. If you tell the patient that you're a spinal, boring everyone with the orthopedic example, but if you tell the patient that you can have either a general anaesthetic or a spinal anaesthesia, clearly there are some clinical benefits for one over the other, but patients still have a voice and a choice as part of that. So then if you arm them with, well, one option is much more sustainable, do they then make a different decision, or does that factor into their decision making? And you can flip that into the clinical side as well. So we've done some really interesting exploratory work. I think there is some age demographics. I think definitely younger patients would prefer, more sustainable options. The older ones just want care as fast as possible. But again, there are some, it depends on the question you're asking. Obviously, if it's access to a local facility, then the elderly would prefer that. But it is really varied.
Quite often the fastest option is the more sustainable one. And
Agreed.
Having a waiting list for a general anaesthetic is quite a long time. But we've seen in our dental hospital as well, doing much more complex dental cases. When I say complex dental, I mean anaesthetically difficult, people with quite advanced learning difficulties, dementias, that wouldn't normally tolerate general anaesthesia. Now having it done under quite novel pharmaceutical techniques, like new drugs that have come to the market recently, like Remy, Masalam, which are really good sedative techniques, which have a much lower carbon footprint than a general anaesthetic. And it means they get done way quicker. Paul?
In terms of my field that I normally work in, travel and transport, it's a bit of a mystery. No one really collects information about how patients travel to healthcare, and it's something that we're going to have to start filling the gaps in over the next 2 years. Actually, only about half of hospitals ask their staff how they commute, or how they'd like to commute, what might make a difference for them to leave the car at home and try something else. So our job this year is to get that up to as close as 100% as possible. And actually, in the course of the last couple of months, we've gone from a baseline of about 43% of trust surveying their staff to over 70%. So we are getting there. But that's the first thing. If you're going to create a sustainable travel plan that works for your staff and your patients and your visitors, you can't make any assumptions, because it's so intrinsically local. Like, what might work in London with a good public transport connection won't work in Leicester, for example. But probably the best example nationally of where we've really involved the patient is in inhalers and asthma care, because actually moving to a less intense kind of system, and you'll know this, Nadia, but like people that use the most inhalers, conversely, usually have the worst control of their respiratory symptoms, and they just use inhalers because they're using it to mask that. So having a proper structured conversation with patients about what they need, their behaviours, making sure that they're using the inhaler properly, and giving them a choice about what inhaler they use, not simply just between dry powdered and metered dose inhaler, but lots of other things, and making sure they're equipped to manage their own healthcare has a myriad of benefits: financial, patient outcome, carbon as well. And that's a really good example of things nationally that a national framework's been been set up, but then individually in groups of GP practices and in hospitals, they've really taken that forward and found ways to reach hard to reach communities. So it's a brilliant example of setting a national ambition that makes sense, but then giving people the space and the tools to develop a approach locally that actually respects their local patient's voice and includes people who are otherwise not really consulted. It's a great example.
Absolutely.
Thanks, Johnny. Just a question. So we're very used to the National Institution of Clinical Excellence. Is Greener NHS integrating with that, or is there a separate body that evaluates clinical interventions from a sustainability perspective?
I'll hand over the clinicians around that, but Green NHS does have a relationship with NICE, and we do encourage them to assess the new kind of lower carbon technologies as they emerge.
I guess it's not about NICE, but the CQC have added sort of leadership and sustainability and leadership. I think Johnny will correct me if I'm wrong, but I don't specifically know about NICE, but I think the large organisations are moving towards including those measures.
Yeah, as far as I know, NICE is still very focused around QALYs, and so hasn't yet built sustainability in as a sort of data point, as far as I know. NICE are going through a bit of a transition at the moment, so they've got an industry consultation that's happening now to see how they could make themselves more relevant for industry and the NHS going forward, because there is a slight concern that NICE can't keep up with this pace of change. So that's happening. I'm not aware of sustainability per se, and it may, to be honest, it may be outside their remit to some extent, unless you're looking at national commissions, because often that purchasing decision is local. So provided you're hitting the procurement thresholds, or you're demonstrating social value and environmental value, then that shouldn't be a blocker necessarily. So again, I don't know exactly where NICE will land in terms of its regulatory sort of ability around net zero in particular.
I mean, you could argue that historically they've been doing it all along, sort of, deciding what is good quality care that we should be funding. And what I've seen recently, especially in the discussions around desflurane, the anaesthetic gas that we saw that beautiful graph at the start. Recently, I was at NHS England, actually having a meeting, going through the NICE evidence about whether there would be certain specialities where desflurane should still be used, and then NICE, be able to provide a really good evidence summary to suggest that actually for bariatric surgery and neurosurgery, there still is no evidence base for this drug. Why are we using it? Any more questions?
Hi there, thanks for the talk. It's been very, very interesting. I'm an innovation consultant. I'm working at the moment on an initiative to move in-clinic long-term treatment into people's homes. There was quite a lot around consultations and assessments, and there were some mentions of kind of remote wards. How much, I couldn't get a sense, and I have really struggled to get a sense of how big a part of the picture is moving long-term treatments into a home setting, and is it straightforward from a carbon point of view, or actually is it one of the areas that's more complicated in terms of carbon? I can see it would be challenging if we don't know how patients are travelling to the clinic. That would make it challenging from that point of view to.
I mean, I can talk quickly about paediatrics, because there's a very big move for this kind of hospital at home idea where you get people out quickly, but you have nursing teams who are still going to go in and check on them like once or twice a day, give antibiotics at home. And that's been established in paediatrics for quite a long time. But now, like particularly with winter pressures, there's a very strong driver to kind of build capacity in that area. It's always been something for inpatient wards, but it's now also for A&E, paediatric A&E. So I think there's some issues around the governance structures and making sure that you can demonstrate, but from a patient safety point of view, it's really they're very effective and cost saving, and it's just locally kind of finding the resource to do it. But it's a well established model in paediatrics for sure.
when the pandemic hit, I was managing a number of services at King's, a lot of medical specialties, and a lot of those moved almost overnight to remote model, and a lot of them have stayed like that, and it's the same case nationally. Really, you do need, you know, a reliable technology platform. You probably do need, you know, some telemedicine out there. For example, we're now monitoring a lot of diabetes patients remotely, and it's great. It's great for them. They don't have to keep going to the hospital every you know, few weeks to submit a reading that they can just take at home and submit. So at one end of the spectrum, we were moving ophthalmology out, you know, and doing that remotely. We needed very high spec cameras, but again, this model's been in place in places like Australia and Scotland for years and years. So it's not, you know, the pandemic accelerated a lot of this thing, and a lot of it's been embedded. But there's will be some great data on NHS England's website about you know, the proportion of that care that's delivered remotely. We've seen a massive surge. And then for you know, one of the other crucial elements is a portal whereby patients can contact the hospital, or patient-initiated follow-ups, we call them. You're probably familiar with those. So don't bring the patient back every 3 months just because they've got, you know, IBD. But, you know, when they feel like they need to access a clinician, they've got a quick and reliable way of doing that, and it's not by email. It's like, you know, some kind of portal where they can log on, they can have you know, a remote or a face-to-face consultation with a patient, with a hospital, with a way to get them into hospital quickly if they need that. So there's some of the key elements. But the pandemic has really proven that's possible, and at some point we were doing 40% of our follow-up outpatients appointments remotely, and that won't be unusual. There's you know, one of the lasting, I guess, positive things from the pandemic, if you can call it that, is the ability to now transform outpatient care in those kind of ways.
Yeah, I think that's really interesting. There's a couple of things to differentiate, I would say. One is care at home versus care in a community setting, because again, sometimes you might need a definitive diagnostic, you know, like a camera or something. So I think there are different groups of patients. The slight concern I've always had about patient at home is you often introduce a lot of noise into the system because you're sending out a diagnostic adjunct or whatever into the patient's home. Do you know, is that a real reading or is that not? You've then got a worse workforce restriction. So at the moment, quite wide, you know, everywhere has a workforce restriction. So who are you resourcing that care, batch of care with? You're often pulling it from frontline or inpatient care, and they are too stretched to do it. So I still think there's a little bit of work to do, particularly around solving that workforce restriction. If you can, then I think absolutely there's lots of models at home that work great. But ultimately, if you introduce noise and no extra staff or workforce, then are you going to have any benefits? And I think that's where my gut instinct on why virtual wards have struggled a little bit in recent times, because you know, what is the number needed to treat on a virtual ward to actually have a meaningful impact versus, say, having a very clear PIFU pathway of just saying, these are your criteria, call us if you hit any of these, and then you just come back to see us. So, or go to a community diagnostic facility. So I think there is some subtlety there that hasn't yet been unpicked and unravelled.
That's a really good point. And I think what you were saying about having that contact as well for patients to have, where they know if they are in one of those sort of virtual scenarios, or what I've seen happen recently with HIV care, for example, patients who are deemed as having, you know, a low viral load, they're stable in their disease. They do not need to keep coming back for multiple appointments, but they have that option, that virtual nudge that means that if they do need an appointment, if they do need some checks, they can get them done quickly without having to get back into a whole referral rigmarole. Any other questions? Okay, Gus, thank you.
Hi, thank you for everything and all the information that you've provided so far. Sorry to put you on the spot. Maybe you do know, maybe you don't know about the federated data platform that's coming into use. Oh, okay. Is there any information that this platform will provide on sustainability at all, or do you know anything about what it might prove in the future? Thank you.
I definitely don't know anything about it. I would love to know more, though.
I mean, there is information that NHS England currently have, the Greener NHS dashboard, which starts to show by trust or integrated care system level some key metrics like the use of Desflurane, for example, or carbon footprints on travel and transport. In the new federated data platform that NHS England will be commissioned, we only look to expand from that, but it'll be a slow and steady journey. You can appreciate the new federated data platform will cause quite a lot of turbulence to begin with. So really, it will just be about kind of getting that set up and running. But yes, there will then be opportunities to develop a lot more sustainability tools in the background. There's various teams at NHS England working on what those products and data services might look like, but don't expect anything for the next couple of years, because I imagine it will be pretty bumpy.
Just to add to that, I think that like when these big changes are happening, it's just even more of an important time for clinicians to kind of be awake and try and be involved, because I think if this platform, what I've understood from it is that there's a lot of difficulties that clinicians have with it, and I think if we're not quite eye on the ball about what it actually needs to do and how it should serve us, then it's not necessarily, it's going to be very turbulent, and we're going to have missed an opportunity. So thanks for the question. I best get a bit more involved, I think.
So look, this draws us to the end of the Q&A. Thank you, you three, so much for sharing your wisdom with us. Guys, round of applause for them, please.